So going back to immune therapy, that was the first one we all jumped on. And we always, when we start with new treatment, we start in the second line when patients have progressed after primary treatment. We try that. And we showed that the single agents immune therapy like dostarlimab or pembrolizumab, these two drugs are approved on both sides of the pond. These patients are who are DMMR, who are hot tumors, their single agent immune therapy was good enough, giving really great responses. Because we know in this situation in second line, chemotherapy has quite low response, 10%, 10, 15%, and we could see the responses of 45 to 50% with dostarlimab or pembrolizumab. And then we saw the first phase 3 trial, also in second line, for addition of another molecule, new molecule, which is so-called tyrosine kinase inhibitor. So it was pembrolizumab plus lenvatinib, showing both benefit in responses, that patient was kept disease-free for a longer period, and there were more patients who were alive at certain time after it was certain time period of cutoff. So altogether, that really showed us that immune therapy is changing everything for our patients to the better. But it was clear that we cannot cure the patients if we keep the immune therapy in second, third line of treatment. If you really want to cure the patients, you have to push that treatment up front. You don't have to wait that they progress after carboplatin paclitaxel therapy. And they started a tsunami of phase 3 trials a few years ago asking this question. Basically, 3 questions are being asked here. These trials, these 4 trials are asking one question. If we add immune therapy on top of standard of care chemotherapy, and standard of care chemotherapy is carboplatin and paclitaxel. So these all trials are asking that. We have shown very, very interesting results. I'll come back to you in a moment. The second way we are looking at is that once we have added immune therapy to chemotherapy to these patients, on top of that, can we also add PARP inhibitor and get more benefit out of that? And we have already seen positive results of both trials, and we have already seen that European Medicines Agency have approved Duo-E for the treatment with PARP inhibitor. So I think this is a great story as well. Last but not the least, we started exploring, can we not give carboplatin paclitaxel, especially paclitaxel, which is quite toxic, neuropathy, hair loss. Can we save these treatments for the time of relapse? And these are the trials which are asking this question. The LEAP-001 is something very similar to what I just showed with pembrolizumab. And then you have trials only in the hot tumors where chemotherapy is replaced by immune therapy. We don't have results of these trials yet. We would know that.